Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Schaefer, and today I'm honored to invite to the podcast two guests, both of whom have contributed hundreds of works to our profession and probably need little introduction. First, we have with us today Dr. Cesar Fernández-de-las-Peñas. He works at the University of Rey Juan Carlos in Alcorcón, Spain, where he is the chair of investigation and teaching of physical therapy, manual therapy, and dry needling. Second, we are honored to have with us Dr. Joshua Cleland. He works in the Department of Physical Therapy at Franklin Pierce University in Manchester, New Hampshire, the Department of Rehabilitation Services at Concord Hospital in Concord, New Hampshire, as well as the Manual Therapy Fellowship Program at Regis University in Denver, Colorado. Dr. Fernández-de-las-Peñas, welcome to the podcast.
Hello.
Dr. Cleland, a warm welcome to you as well.
Hi, thanks, Steve.
Gentlemen, it is a pleasure to have you both here today. As most of our audience should know, you have both been very prolific within the profession. And on the lighter side of things, I understand you're both physically located in Spain right now.
Yeah, so I'm lucky enough to come here and work with Cesar the first 2 weeks of July every year, where we get to work with some of the PhD students, and then we write papers for the next 2 weeks. So a busy 2 weeks. So July 4th holiday is not a holiday for me. Cesar's got me working and writing papers.
Excellent. That sounds amazing. I happen to personally be a big fan of Spain. I've been there a handful of times, and quite frankly, I'm a bit jealous.
No, it's nice, but you don't need to believe him at 100%, because also we have some days of holidays for a swimming pool, for Spain. It has a very good time for coming here for work and also for rest and also for visiting all the places that we have around Madrid. So it's very nice these 2 weeks with my friend here.
Yeah, great.
Again, gentlemen, that sounds excellent. So getting to the topic at hand, you were both recently among the authors of a paper that was titled Cost Effectiveness Evaluation of Manual Physical Therapy versus Surgery for Carpal Tunnel Syndrome, Evidence from a Randomized Control Trial. For the knowledge of our audience, this was published in the Journal of Orthopedic and Sport Physical Therapy in February of this year, 2019.
Yeah.
In terms of introducing the overall topic, and pretty much every physiotherapist in the world knows what carpal tunnel syndrome is, can you talk for a moment about the financial impact of carpal tunnel syndrome on people?
Okay, I think that this question is usually related to the country that any PT live, because usually the financial impact of carpal tunnel syndrome in Spain probably would be different from USA or for Australia, other country. But at least in my country, usually this neuropathy accounts for 5% of the people with peripheral neuropathies in the upper extremity. So it's a huge impact, because usually carpal tunnel syndrome is considered a laboral or working disorder. So people that is active working, usually working with the hands, can suffer from carpal tunnel syndrome. So I think that the social, the work support, the laboral, and also the healthcare involvement is huge. And also the impact on the economy usually is huge, because probably, as we have done in the study, the surgical treatment, the surgery is the first treatment option in all countries. So probably this will have a huge impact in the economy, on the healthcare system. Probably in USA, I think that there are much million people than in Spain, so probably there are much million surgery on this topic, and probably Josh can have also some comments on this topic in related to USA, I think.
Yeah, so Steve, I think in the US, the treatment for carpal tunnel syndrome exceeds like $2 billion annually, which is a huge impact on folks and society in general. And often the first line of intervention, as Cesar mentioned, is surgical. And we have shown here in not just this study, but a couple of other clinical trials that we've worked on together, that PT can be just as advantageous as surgical intervention. And from the study you're referring to now is probably more cost effective as well.
Yeah, and of course, those are some perspectives from a couple countries. But if you magnify that out and think about the number of people globally, we're talking about a relatively large problem.
Yeah, relatively large too. And we're talking about some countries where we're pretty well off financially and with healthcare resources. But I also think some of the other countries that are not so well off are probably having more cases of this for the like factory workers and farm workers and stuff like that. So I think globally this has a big impact.
When we start talking about carpal tunnel syndrome, one of the things that comes to mind is that there are different diagnostic criteria for it. Can you talk for a moment about the inclusion and exclusion criteria that you utilized in your study when considering this question?
Yes, I think that it's very important to make the distinction between real carpal tunnel syndrome, a neuropathy of the median nerve, and also symptoms similarly to carpal tunnel syndrome that is in the hand. Because in PT, at least here when we treat in private practice, many people can have or attend to the PT therapy clinic foreseeing with symptoms similar to carpal tunnel syndrome in the hand. They have pain, they have numbing, they have some sensation into the three fingers, into the thumb, into the index, and the ring fingers, and you can think that okay, this is similar to carpal tunnel syndrome. They can have some clinical signs like the tunnel sign or the Fallen sign, that they are the two typical clinical signs or symptoms usually used in the clinical examination of carpal tunnel syndrome. They can have positive. But I think that this is the symptoms, and to have a clear diagnosis, that is what we did in the study, we need to get a positive AMG findings. Because without positive AMG findings, we cannot say, okay, this is a real neuropathy of the median nerve as carpal tunnel syndrome. So I think that in the study, we get clear patients with both clinical symptoms and also the AMG positive findings to say, okay, this is an inclusion criteria to get into the study.
Yes, Steve, I'd like to just echo Cesar's comments that we made sure that these folks had carpal tunnel syndrome, and EMG findings it told us as such.
That's excellent. And that's one of the things that stood out when I was reading the paper, because in my clinical practice, for example, carpal tunnel syndrome is one of those catchphrases. It's one of those things that when it comes across my desk, it puts 5, 10, 15 different ideas in my head, because people use the label all the time, but it isn't necessarily what's present clinically. So I was very pleased when I wrote in the paper that you had these criteria to try and be as specific as possible.
Yeah, so we did that to really to increase the internal validity. But I think when those folks come to your office with a diagnosis from the physician of carpal tunnel, it may have not had EMG findings. I think the treatments we used, if you weigh the risk benefit ratio, I think they would perhaps be a benefit with no risk involved.
I certainly agree with that. And from the physical therapy standpoint, I'd rather have them come to me first, and then maybe I fail. Maybe it's a situation that requires surgery, et cetera. But I would rather have me fail first and then send them off to surgery, as opposed to the opposite, with surgery first, have that not work out, and then the patient come to me and have my services be more helpful.
Yeah, I think we would both agree.
Yeah, and also in Spain, when someone has starting with these symptoms, usually the first therapeutic option, obviously before saying that okay, you are indicated for surgery, usually is the splints. Usually, most people that have started with symptoms similar to carpal tunnel syndrome or real carpal tunnel syndrome, they usually receive splint therapy. The first option is okay, if you have symptoms into the night, you can buy a splint into the orthopedics and try if the splint release the symptoms. Also, you have symptoms into the work, buy a splint and use the splint during work. So I think that this is the first therapeutic option, I think, around the world, the splint.
Yes, see.
In my current practice, it's mixed. Some people come to me directly. They come to me from a physician. They come to me before or after surgery. I haven't been working in my current job long enough to have any comments on splints, but I've definitely seen that option in the past.
Yeah, probably. In Spain, it's not commonly to see that any medical doctor, it will be a surgeon, it will be traumatologist, either physician, usually send the people with carpal tunnel syndrome to PT. I think that it will be the own patient that they say, okay, I'm not getting positive results with any medical option, so I visit a PT just in case they can help me. But we don't usually receive patients from any other professional about this topic.
Right. And so to be clear, Steve, so in these studies, we treated like really the mechanical interfaces around the nerve. So the structures that are around the nerve, such as the cervical spine, the musculature, everything of that nature was treated in this treatment approach. So I think that's appropriate for folks that are managing individuals with carpal tunnel syndrome. And so really just treating the structures around that nerve and trying to quiet those down and decrease perhaps some of the compression on the nerve seems to have been clinically effective as well as cost effective.
You just walked right into the topic I wanted to get to next. So I want to give you an opportunity to expand on that. You mentioned the cervical spine. You talked about working on the tissues that interface with the nerve. Can you give me a general list or idea of all the different things, or perhaps the major things that you think physical therapists should be looking at, testing, working on, et cetera, to try and make the nerve healthier so that the carpal tunnel syndrome, which most people consider as having symptoms in the wrist and distal, can get better?
Yeah, I think that today we have clear evidence that the people with carpal tunnel syndrome doesn't have only symptoms into the hand. When we start with this kind of study, it was, I think it's 2009, so almost 10 years ago, because we have seen that people with carpal tunnel syndrome diagnosis has also pain symptoms in the upper extremity. Always, not only neck pain, but also shoulder pain or symptoms are of the forearm, not only into the hand. So I think that I will be around 80% of the patients with this syndrome will have upper extremity symptoms. But there will be 20% only that they have only exhibit pain into the hand. And I think that they are the most difficult people treatment, because it has been demonstrated that people with only just symptoms into the hand, they have the more severe damage into the nerve. So I think that at the beginning, most people will begin with symptoms in the upper extremity, but they will focus on the hand, because you know that the hand is usually used for working, for management of daily life. So symptoms into the fingers, okay, I cannot open the door with my keys, I cannot properly drive in, so it will be the more afraid for the patients. But I think that the symptoms are in all the extremity. They can start in the neck, they can focus in the shoulder, in the elbow, or in the forearm. So I think that at the beginning, if I have a pity that I have a patient with carpal tunnel syndrome, in the first beginning, in the clinical history, I need to ask, okay, where is the symptoms and where is the relationship between the different places of the symptoms? For example, when you have more neck pain, you have more hand symptoms, or the opposite. Okay, you have shoulder pain. The pain starts in the shoulder or starts in the hand, goes upwards into the shoulder, in the opposite. So with the clinical reasoning that we usually apply with PT, we can focus, okay, where is the beginning or what is the pathway of the pain pathway in these patients? And with this one, we need to think in the clinical approach for this particular patient.
Yeah. And so in these studies, Steve, we treated the cervical spine, really sort of like pec minor where the nerve exits, bicipital aponeurosis, pronator teres, and palmar aponeurosis as well. So we really treated all of the structures that are intimately related to the median nerve.
I think that our real clinical reasoning was, okay, 20 years ago, it has been demonstrated that the clinical neurodynamics, so that we need to move the nerve to get a healthy nerve. But the problem was, at least in Spain, and it was our experience, it was that many people start to move or to release the nerve or to improve the mechanical sensitivity of the nerve. But to be honest, before the nerve runs between the aponeurosis, between the muscles, between different interfaces. And if there is any, we can say, sensitivity in this interface, if we don't release before the interface, the median nerve in this case, or any other nerve, will be not benefit from any treatment because there will be an increase on the sensitivity. So the clinical reasoning for this study and all the study that we have done in carpal tunnel syndrome was, okay, we need to first to release or to decrease the sensitivity in the interface. So we get the textbook of anatomy and we say, okay, where is the origin of the median nerve and what is the end of the median nerve? And we treat manually all the interfaces where the median nerve can be potentially irritated or stimulated.
I really like that approach, and it reflects very closely what I do when I'm in the clinic. And I think that the situation is appropriately complicated to think that broadly. One question it brings to mind, and this is obviously something I have a clinical opinion on, but I would love to hear what the two of you think. Historically, we've used the phrase, quote unquote, double crush. And that implies that if the nerve is impacted in two locations as opposed to one, then it can magnify the overall symptom presentation. But part of what you're describing is we need to check more than two locations. Let's put 4, 5, 6, maybe even more locations than that on the list. What are your thoughts on that overall description and maybe how we could better describe the situation?
First, I think that is not accepted by all healthcare professions. So I think that it will be okay. It's only a proposal. But the problem with the double crush theory is that they say that this will be a real entrapment of the nerve. For example, if we get a cervical arthrosis or osteoarthritis, it will be a first place of entrapment because there is a real damage of with the osteophytes in the cervical spine, then they can trap or decrease the movement of the median nerve. And also, for example, the second one will be in the carpal tunnel with the transverse ligament over the median nerve. But here we are not talking about real entrapment. We are not discussing, okay, the median nerve can be trapped into the pectoralis minor, in the bicep brachii muscle, or in the aponeurosis. Not, it's only the sensitivity of the interface. I think that we need to change the thinking about the entrapment, and it will be changed to the interface. There is an increased sensitivity or increased sensitization in these places, because it's not only a real entrapment of the nerve, it's only an increase of sensitivity in this place. We have seen many studies, not many, some studies on carpal tunnel syndrome demonstrating that there are a reduced movement of the median nerve excursion, so there is a real entrapment, but others, there are no changes, there are no difference in the median nerve excursion. So can you explain how a people with a carpal tunnel syndrome diagnosis, from an AMG and clinical point of view, has negative neurodynamic findings? There are no restriction of the movement of the median nerve. And in the clinical practice, we have seen, we apply the upper limb tension test, number 1, for the median nerve, and there is negative. Why? If it will be a real entrapment of the nerve, always will be positive. So I think that we are not discussing the double crush theory only says real damage or real entrapment of the nerve. We are thinking in the same clinical application, but we are making more precise with the terminology that we use for explaining the proposal, I think.
Yeah, so I think, Steve, I think double crush is probably a nomenclature that's perhaps a bit outdated. And I think we need to really work on just all the structures. And as Cesar mentioned, the mechanical interfaces that surround the nerve. Clearly, there can be some regions of sensitivity or irritation at a number of different sites. And so I think that's probably a plausible theory for some of these neurological conditions.
I really like that explanation. And again, it matches up so well with my clinical practice and how I've thought about the research. I do want to maybe push this one step further and add something to the list. I find that I get pretty good results with these patients when I work on the ribs, and not just the first rib, which is right there where the brachial plexus traverses, but sometimes as low as the 4th, 5th, and 6th rib. Have you had any experience with that in the clinic?
I think that if we use the anatomy, the pectoralis minor muscle attached to the 3rd and the 4th and 5th rib. So maybe when we treat, for example, the thoracic spine or the rib cage, we have also different effects on different muscles or tissue that they are around it. So if we think on this patient with carpal tunnel syndrome, obviously if we treat the 3rd, the 4th, or the 5th rib, we have an impact on the pectoralis minor that it has an interface of the median nerve. So it will be the first thing that I would think if you ask me, okay, why is the relationship between when I treat the rib cage, I can get a positive or something effect into the median nerve, because there is anatomy relationship with the pectoralis minor that has an interface that we need to release for this kind of patient.
I think that's a great explanation, and I like how it all fits in terms of the anatomy. And I also think one of the great things about that is it's really easy to show a picture to a patient and then explain the relationship between those tissues. And I think once people can see it in their head, once they understand that it makes sense, it does things like helps buy into what we're telling them. It helps them with adherence to their home program. So again, I think that was a great explanation.
Yeah, I think that today, physical therapists, we need to bring together the anatomy and the neuroscience, because always I think that there is a gap and a bridge between both of them. Not only anatomy, but also the new neuroscience that we have updated in the last 10 years. And I think that both together can explain most of the treatment that we usually apply to any kind of patient with musculoskeletal or neuropathic pain in this case.
Getting back to the treatment, when I was reading the paper, I noticed that you limited the treatment sessions to only 3. Why was that?
Oh, to be honest, this was being pragmatical reason. We have many patients to treat in the study. We treat 60 patients and we made different studies. This was the original clinical trial that we started to plan at 2009, and the cost effectiveness analysis was done some years after the finishing of the trial. But 60 patients, we are only 2 3PTs here at that time making the study. So we need to thought, okay, we cannot make 5, 6 sessions because it will be 400 sessions. So to be honest, it was a pragmatic decision. We say, okay, 3 sessions, it will be enough, because also in our clinical practice, we don't usually treat many times a patient because we believe that the patients need to integrate some home exercise. They need to be integrated into the clinical treatment. So we say, okay, 3 sessions, and we teach the patients different exercises, and they have enough time between sessions to session once a week to rest or to integrate all the things that we have corrected into the session. So it was a pragmatic decision. It was not a real, okay, there is no evidence how many sessions we need to take for these patients.
Right. So Steve, just to follow up on that, we don't know, maybe 4 sessions would be better, 5 might be better. But as Cesar mentioned, for the healthcare system here and to be pragmatic, it worked pretty well to have 3 sessions. And we also felt that this would generalize to the US and other countries as well that maybe have limited number of visits. And so rather than having 10, 12, 15 visits, we thought 3 would be generalizable across really globally.
I like that thought process. And of course, we all know that different patients respond differently. Some people need more, some people need less. But if you can make positive outcomes in 3 visits, it's a good indication that it's the type of approach that we should move forward with clinically.
To be honest, we were very surprised that only 3 sessions get a very good response during long-term follow-ups. It was very, very impressive for us. So we don't expect it, because we agree in clinical practice that we have patients that we have very good results with just 1-2 sessions, but they are the small percentage. But many people usually need more sessions. We don't know how many. And also the patients were very surprised that they don't need more treatment, at least direct treatment with the PT, because most of them, they have doing the exercise during the year because they see that when they stop it to make the exercise that we teach them, the symptoms progressively started again. So they can manage their own symptoms with the exercises before needing more treatment during the year.
Let's expand on that a little bit and go further into the results, both clinically and financially. What did you find after you crunched all the numbers and looked at the data?
Okay, when we made the cost effectiveness analysis, it was a huge analysis because it was the first time that we make this kind of analysis in our research life. And it was very nice because we know that the surgery procedure here in Spain has this cost, and usually they take around 1 month to recover. I think that the more expensive or the more different from a financial perspective was this month of work absence, of medicines, visit to the medical doctors, if there is any side effect of the surgery. So I think that this month will be the key for the differences in the real cost between the manual therapy group and the surgery group. Because we need to consider that no one into the manual therapy group had a work absent during the treatment, because they don't need to recover as they need to recover from the surgery.
One of the points there, of course, is that while surgery is a treatment, surgery is also an injury. And I think it's interesting and, of course, appropriate that you're looking not just at the cost of healthcare, which is what people often look at, but the overall financial burden from a societal standpoint.
Yeah, agree. I think that the real difference is not only the procedure, obviously, because the surgery is more expensive than the manual therapy. And also it will depend on the country, but in Spain, I think that the surgical procedure was cheaper than other countries. I'm sure that it will be much cheaper than in USA.
Mm-hmm.
And also the PT sessions, we put 50 euros per session, that this is expensive in Spain. So we use the analysis, the worst analysis against PT, because there are, for example, many PTs in Spain that they usually get one session per 30 euros, other for 60 euros. So we decided to put 50 euros per session for the cost that it was high for Spain. And also the surgery procedure is also cheaper in Spain than many other countries. So probably if we repeat the same procedure or the same analysis in other countries, maybe the difference will be much higher in favor of the physical therapy group.
I really like the overall progression of this as it relates to the evidence we've had in the past for carpal tunnel syndrome. Where do you think the next step is from this? Because a lot of these variables to me sound like a partially new direction, a partial episode of care. You've begun to look into this overall approach. Where should we go next?
I think that the first thing to do is that clinicians understand that the treatment of carpal tunnel syndrome is not just local. The problem with all the systematic reviews and all the meta-analysis that has been done in carpal tunnel syndrome, and they compare the conservative or physical therapy treatment versus the surgery or the surgery treatment, all the meta-analysis say that surgery is more effective at long term. The problem is that if you see the analysis, most PT treatment are focused just only into the wrist. They use laser, they use ultrasound, they use splints, they use corticoid injections, but only into the carpal tunnel. So this is the reason why we made this study. We need to understand that the treatment of carpal tunnel syndrome is not only focused on the carpal tunnel or in the wrist. It should be focused on all the upper extremity. So I think that the first point of view for changing the mentality is that carpal tunnel syndrome needs to be treated globally, not only locally. And obviously, I think that we need more studies, including this clinical reasoning, for saying, okay, we found the same things than in Spain. Now I know that I think it is in Finland. There is a group that they contact with me that they want to reproduce a similar or the same study with more patients with carpal tunnel syndrome, including both men and women, and to see if the findings in Finland is similar than in Spain, to see if this approach is going to be more effective than a local approach to carpal tunnel syndrome.
Yes, Steve. So I think as Cesar mentioned, the next step is probably breaking this out geographically, and the next study is going to be kicked off in Finland, and I think we probably also need to do something similar in the U.S. It's just finding folks that treat this population or are willing to contribute to a clinical trial.
That sounds like a great direction to go in. And listening to your answers, one of the things that I can't help but think about is perhaps the name carpal tunnel syndrome in itself is part of the problem because, the carpal tunnel is located right in the wrist, but we're talking about treating things all along the nerve so that we can deal with those different interfaces. Have you ever thought about trying to propose a new name for the condition or trying to move the research in that direction?
I think that the carpal tunnel syndrome is a medical diagnosis. And I think that as PTs, we need to adapt and to understand that the medical diagnosis is this one, because I think that the name of carpal tunnel syndrome is based that the EMG analysis is made into the wrist. So they find changes in the EMG conduction at the wrist level of the median nerve. So I think that the name will be, okay, it's carpal tunnel syndrome, it's a medical diagnosis. But as PT, we need to understand, okay, what is the origin or what is the contribution of other tissues of these symptoms in the carpal tunnel. I think that this is a similar understanding that with the headache. The headache diagnosis is headache, migraine, or tension type headache. Okay, this is the medical diagnosis. It is based on different clinical symptoms. I agree. But as PT, we need to understand what is the origin or different contributors of, in this case, headache or carpal tunnel syndrome. I think that trying to changing the names will be very difficult because what can be a good name? Upper extremity neuropathies? No, because ulnar nerve, ulnar neuropathy can be also. The cubital syndrome, it will be the similar thing. Okay, the cubital syndrome has symptoms into the ulnar nerve, but the place of the interface can be in the neck. So all neuropathies should be follow the same clinical reasoning. So we can changing the name it will be to lose all the medical diagnosis and to say, okay, any neuropathy in the upper extremity can need to understanding that there are many clinical interfaces in the upper extremity. So I think that we need to adapt it. I think that we don't need to propose any other name. We have many names in the world to changing, so I think that we need to bring together the medical diagnosis with the PT understanding.
That is an excellent answer, and I couldn't agree more. For what is perhaps the last question, and knowing the two of you, perhaps a potentially very dangerous question, so keep it reasonably brief, but do you have any projects in the works that our audience can look forward to seeing in the future?
Oh my God. We have followed these patients 4 years after the end of the treatment because we have seen there are some reviews saying that 80% of people that at the beginning of the symptoms or at the beginning of the treatment with carpal tunnel syndrome, if they receive conservative treatment, in this case, splints, steroids, injection, laser, ultrasound, 80% of them in the next 2-3 years, they receive surgery. So this is not a good outcome because this review says that all of them will receive surgery. So with this in mind, we have followed the same patients in the surgery group and into the manual therapy group during 4 years without no further treatment. And only in the group of manual therapy with this approach, only 20% of the patients in the 4th year receive surgery. So we have data saying that 4 years after the treatment, they still maintain some of them the clinical improvement in a similar way than the surgery, and only 20% of the patients need surgery. So this is a huge decrease in the percentage of the understanding on carpal tunnel syndrome because all studies says that 80% of the patients that they receive local treatment need surgery. But with this study or with this data, we have demonstrated that, or the opposite, only 20% of the patients that has been properly treated needs surgery 4 years after the treatment. So in this topic, this is what we are doing or trying to finish to collect the data in this topic of research.
And from you, Dr. Cleland?
Yeah, so we got a number of different projects going on, including the carpal tunnel stuff, lumbar radiculopathy, neck pain, bicipital tendinosis, tendinopathy. So a number of clinical trials that I'm fortunate enough to work with Cesar on, and we'll have hopefully some data to report in the next year or so.
That sounds absolutely amazing. We look forward to seeing that in the future. And if our audience wants to get a hold of you, maybe to ask a question, etc., how do they find you?
Yes, I can be found at Franklin Pierce University, Doctor of Physical Therapy program. They can just look me up there, and they can send along an email to me, and I'll be glad to respond.
Yeah, and as you have seen in the presentation, I'm in Spain in Alcorcón from 20 years ago. I work always in the same university. So Universidad de Juan Carlos is like the name of the previous king of Spain, so I'm very proud to be there. Anyone that come here to visit us is also open and is more than welcome to help us in any of the studies that we are doing because we need hands as carpal tunnel syndrome because we have many work here to do. So anyone is welcome.
Well, gentlemen, there's no doubt in my mind that there will be plenty of opportunities to have both of you back in the future because, as I said before, you're just so prolific in the profession, and it's great to have you on the program today.
Great, Steve, and thanks so much. And I just, in closure, I just want to say that I'm proud to be a keynote at AOMP this year with Lori Mishner and Allison Grimaldi. So a couple of really spectacular females that I'll be presenting with down in Orlando in October. And I hope that all the folks listening can attend and be there to share in the excitement and the intellectual stimulation.
I, for one, will be there, as will my other co-hosts. And like you said, we look forward to seeing the audience there as well.
Great.
Gentlemen, have a great day.
Thanks, Steve. You too.
Thank you very much, Steve.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.